Occupational English Test. Listening Test. This test has 3 parts. In each part, you'll hear a number of different extracts. At the start of each extract, you'll hear this sound. You'll have time to read the questions before you hear each extract, and you'll hear each extract once only. Complete your answers as you listen. At the end of the test, you'll have 2 minutes to check your answers. Part A. In this part of the test, you'll hear 2 different extracts. In each extract, a health professional is talking to a patient. For questions 1 to 24, complete the notes with information that you hear. Now, look at the notes for Extract 1. Extract 1, questions 1 to 12. For questions 1 to 12, complete the notes with a word or short phrase that you hear. You now have 30 seconds to look at the notes.
Good morning, Mrs. Davis. I have the information from your primary care physician about your eyes, but since this is our first consultation regarding potential retinopathy, could you start by giving me a brief history of your eyesight and any treatments you've had?
Certainly. I've been diabetic for nearly 20 years now and have been wearing glasses since I was a teenager. My optometrist did mention some changes in the back of my eyes a couple of years ago, but didn't think it was serious at the time.
Have you noticed any changes in your vision recently, such as blurry vision, seeing spots, or perhaps difficulty in recognizing colors?
Yes, in the last 6 months, I've had some difficulty reading small print, even with my glasses on. Occasionally, I also see some floaters and dark spots, especially in brightly lit areas.
Those symptoms can be associated with retinopathy. With your history of diabetes, the blood vessels in the retina can become damaged and leak fluid or bleed, leading to these visual disturbances. Have you been managing your diabetes well?
Mostly. My blood sugar levels do fluctuate sometimes, especially when I get stressed, but I try to keep it under control with medication and diet.
Consistent blood sugar control is essential to prevent the progression of diabetic retinopathy. Have you ever had a procedure known as fluorescein angiography?
No, I haven't. What is that?
It's a test where a special dye is injected into your arm, and then photos are taken of the back of your eye. This allows us to see the blood vessels in your retina clearly and identify any damage or leaks. It's crucial for diagnosing the extent of retinopathy.
Oh, that sounds important. Should I have it done?
Yes, I would recommend it, especially given your symptoms. Early detection and treatment can help prevent further vision loss. Apart from the floaters and difficulty reading, have you experienced any pain or pressure in your eyes?
Not pain per se, but sometimes I feel a bit of pressure, especially in the evenings after a long day.
That's also important to note. Increased pressure in the eye can be indicative of other conditions like glaucoma. We'll have to monitor that as well. How often do you get your eyes examined?
I usually go once a year, but sometimes I miss an appointment if I'm busy.
With your history of diabetes and the current symptoms, I'd suggest more frequent checks, perhaps every 6 months. Retinopathy can progress rapidly if not monitored closely.
I understand. I'll make sure to prioritize my eye health. One more thing, sometimes when I wake up, my vision is extremely blurry, and it takes a while to get clear. Is that related?
It could be. Fluctuating vision can be a sign of swelling in the retina due to fluid leakage. We'll look into it during the examination. Remember, Early detection and intervention are vital to manage retinopathy effectively.
Thank you, doctor. I appreciate your thoroughness and will make sure to follow your recommendations.
Extract 2, questions 13 to 24. For questions 13 to 24, complete the notes with a word or short phrase that you hear. You now have 30 seconds to look at the notes.
I've been dealing with this persistent itchiness for quite a while now, and it's been driving me crazy. I initially thought it was just dry skin, especially since it started around winter, but it's only gotten worse. The skin in certain areas is red, flaky, and sometimes even oozes a little.
That sounds quite uncomfortable. Can you specify where exactly these areas are?
Yes, the most affected areas are around my wrists, behind my knees, and around my neck. There's also some slight redness and itchiness on my face, especially around the eyes.
All right, have you noticed any triggers or factors that make it worse?
It definitely gets worse when I'm stressed or when I eat certain foods like dairy. And when I've tried to moisturize it with some lotions, it sometimes stings or burns.
Noted. Have you used any treatment so far?
I've been using over-the-counter hydrocortisone cream. It provides some relief, but the moment I stop using it, the itchiness comes back even stronger.
Okay, and have you had any allergies in the past or any family history of skin conditions?
I did have hay fever as a kid, and now that you mention it, my mother had something similar on her hands, but I never really asked her what it was.
It's important to note family history as some skin conditions can be hereditary. What about your daily skincare or bath routine?
I usually shower once a day using a standard soap bar. I haven't really been using moisturizers regularly, except for the past few weeks since this started.
It might be beneficial to switch to a gentle fragrance-free cleanser and to moisturize daily. Sometimes standard soaps can be harsh and exacerbate conditions like dermatitis. Also, the use of lukewarm water instead of hot water can be helpful.
I'll give that a try. I'm just tired of this constant itch and discomfort, especially when I'm trying to work or sleep.
I completely understand. From your description, it does sound like you might have dermatitis. However, to confirm, we should conduct a patch test. This will help determine specific allergens that might be causing or worsening the flare-ups.
That sounds good. Anything to get to the root of this.
We'll get that scheduled. In the meantime, I'll prescribe a stronger topical ointment to help alleviate the symptoms. Additionally, I'd recommend keeping a diary of your flare-ups, noting what you ate, stress levels, and other potential triggers. It can help us narrow down the cause.
I'll do that. Thank you for taking the time to understand my situation. It's been hard dealing with this on my own.
It's what I'm here for. We'll work together to manage this and improve your skin's health.
That is the end of Part A. Now look at Part B. Part B. In this part of the test, you'll hear 6 different extracts. In each extract, you'll hear people talking in a different healthcare setting. For questions 25 to 30, choose the answer A, B, or C, which fits best according to what you hear. You'll have time to read each question before you listen. Complete your answers as you listen. Now look at question 25.
Lucia, can you come in and discuss the issue with Mr. Patel's medication?
Yes, I realized I made an error with his evening dose. I gave him 50 milligrams instead of the prescribed 25 milligrams. I've done this administration so many times, but last evening was hectic, and I must have been distracted. I immediately notified the doctor and monitored Mr. Patel for any adverse reactions.
It's vital to be cautious, especially with medications. These errors can be fatal. Was Mr. Patel all right?
He was fine, and there were no immediate side effects. I kept a close eye on him throughout the night.
I'm glad he's okay. Remember always to double-check the prescription, especially during busy shifts. I'll arrange a refresher training session for medication administration for everyone soon.
Now look at question 26.
Hi, Emma. How are you feeling today?
Okay, but my leg still hurts when I walk.
From the information I received, you twisted your ankle during a dance practice. Can you tell me how it happened?
Yeah, I was trying a new move, and my foot landed awkwardly. It hurt right away, and since then, I've been limping.
It seems like you might have strained a ligament. We'll need to conduct some tests and probably recommend a few physiotherapy sessions to strengthen the muscles and improve mobility. Meanwhile, avoid putting too much weight on it and try to rest.
All right, I just hope I can dance again soon.
With the right care and exercises, you'll be back on your feet, dancing in no time. But always remember to warm up before attempting new moves.
Now look at question 27.
Mr. Thompson was brought in earlier this week due to a suspected stroke. He displayed symptoms of facial drooping, arm weakness, and slurred speech when he first arrived. He's a 75-year-old retired teacher with a past medical history of hypertension and type 2 diabetes. His meals need to be pureed because of his swallowing difficulties. Thankfully, he has no known drug allergies. We've started him on aspirin and a statin, and his condition has shown gradual improvement. His neurological exams are stable, though he still has slight speech challenges. His blood pressure has been under control, registering around 135/85 consistently. Earlier today, he had physiotherapy, which focused on improving his motor functions. He's scheduled for a speech therapy session in the afternoon.
Yes, I read about his case. He also underwent a CT scan that showed a small infarct in the left hemisphere. We'll need to closely monitor his progress and potentially adjust his medications accordingly.
Now look at question 28.
All right, team, let's discuss our new dietary plans for the children with celiac disease. As you know, these children have a gluten intolerance, and we must be extra careful with their meals. I've observed that some meals still contain traces of gluten, possibly due to cross-contamination in the kitchen.
That's a valid concern. I've spoken to the kitchen staff about ensuring there's no cross-contamination, and we're considering setting up a dedicated gluten-free preparation area.
Excellent. Moreover, parents have expressed appreciation for the variety in our meal plans. However, a few have voiced concerns about sugar content, especially for diabetic children. It's crucial that we take a closer look at our menus and make the necessary modifications to ensure we cater to these specific needs.
Agreed. We should also think about conducting workshops for the parents. This will help them understand their child's dietary requirements better and ensure a consistent diet, both in the hospital and at home.
Now look at question 29.
Let's discuss our recent admission, Mark Reynolds. Alex, can you brief us on his status?
Absolutely. Mark is a 38-year-old male who was admitted after a major depressive episode. He's been struggling with depressive symptoms for about a year, which escalated following the loss of his job. Presently, he exhibits low mood, persistent feelings of hopelessness, and passive suicidal ideations. We've placed him under close observation, ensuring he's checked every 30 minutes, and we've initiated an antidepressant regimen.
Noted. And what about family involvement?
We've been in touch with his sister. She's concerned, but also supportive. I think a family meeting might be beneficial in the coming days to educate them about Mark's condition and what they can do to help during the recovery process.
Good idea. We'll discuss potential discharge planning once he shows signs of stabilization.
Now look at question 30.
Hello, Mrs. Rodriguez. What brings you in today regarding young Carlos?
We've been noticing some behavioral changes in him. He's become quite irritable, and he's constantly thirsty. He also seems to be losing some weight.
I understand your concerns. Given the symptoms, I'd like to run some tests to rule out type 1 diabetes. It's essential to catch it early if that is the case.
Oh, that sounds serious. We just thought it was a growth phase or something similar.
It could very well be just a phase, but the symptoms you've mentioned warrant further investigation. Don't worry, we're here to help. If it is diabetes, we have resources and support in place to help you manage it.
Thank you, doctor. We just want the best for Carlos, whatever it takes.
I understand, and I assure you, Carlos is in good hands. We'll start with the necessary tests and go from there.
That is the end of Part B. Now look at Part C. Part C. In this part of the test, you'll hear two different extracts. In each extract, you'll hear health professionals talking about aspects of their work. For questions 31 to 42, choose the answer A, B, or C, which fits best according to what you hear. Complete your answers as you listen. Now look at Extract 1.
Good afternoon, everyone. My name is Dr. Lillian Turner, and as a GP in a bustling city practice, one of the common yet often under-discussed health issues I come across is thrombosis. Today, I wish to delve into this topic and share a unique perspective based on my recent experiences. Thrombosis is a term that describes the formation of a blood clot, known as a thrombus, inside a blood vessel which can potentially obstruct blood flow. Broadly, we can categorize it into two types: deep vein thrombosis, DVT, and pulmonary embolism. While DVT usually affects the deep veins in the legs, a PE occurs when a portion of the clot breaks off and travels to the lungs, leading to potentially life-threatening complications. Despite its gravity, thrombosis doesn't always make the headlines. Yet, according to recent research, 1 in every 4 deaths worldwide is due to conditions caused by thrombosis. In our urban setting, several lifestyle factors contribute to the risk. Extended periods of immobility, like those long hours spent at desks or during lengthy flights, are significant risk factors. Additionally, certain medical conditions, surgeries, and even specific medications can heighten one's chances. A few months ago, a 28-year-old woman named Sarah came to my clinic. An IT professional, she complained of swelling, pain, and warmth in her left calf. Given her sedentary job and recent long-haul flight, I was immediately concerned about DVT. My suspicions were confirmed after a Doppler ultrasound. Sarah's case compelled me to launch a thrombosis awareness campaign in collaboration with local community centers. This initiative aimed not just at educating the masses about the dangers of thrombosis, but also offering preventive measures like regular movement, exercises, hydration, and being aware of personal risk factors. Moreover, we also began a pilot program for at-risk patients, encouraging them to wear compression stockings, avoid prolonged immobility, and in some cases, take prophylactic anticoagulant medications. A pharmacist, a physiotherapist, and I led this multidisciplinary effort. Initially, I was met with some resistance. Why fix what isn't broken? Some asked. But soon success stories emerged. For instance, a 60-year-old gentleman who had undergone a hip replacement, usually a high-risk procedure for DVT, followed our preventive program and reported 0 complications. However, there were challenges. Some older patients were apprehensive about wearing compression stockings, considering them uncomfortable or stigmatizing. We overcame this by offering workshops to highlight their importance and provide practical demonstrations for proper wear. In retrospect, the endeavor taught me several lessons. Foremost, the importance of community involvement in healthcare cannot be stressed enough. Through group activities and discussions, people become proactive about their health. It was heartwarming to witness a participant teaching another about the importance of leg exercises during long flights. In conclusion, thrombosis is a silent threat, but with concerted efforts, it can be managed, prevented, and even combated. Just as Sarah's story acted as an impetus for our initiative, I hope my sharing today inspires a fresh perspective on community-driven healthcare solutions. The key lies in being informed, proactive, and collaborative. Thank you.
Now look at Extract 2. Extract 2, questions 37 to 42. You now have 90 seconds to read questions 37 to 42.
Hello, I am Dr. Samantha Green, a neurologist specializing in sleep disorders at our institution. Today, I will delve deep into the intricacies of a condition called narcolepsy, a chronic sleep disorder characterized by overwhelming daytime drowsiness and sudden attacks of sleep. Our journey will encompass the diagnosis, treatment options, implications, and the latest research findings. Narcolepsy affects both men and women equally, manifesting typically in adolescence or young adulthood, though it often remains undiagnosed and untreated. It's paramount to distinguish this disorder from regular sleepiness. Those affected can have sudden sleep attacks at inappropriate times, like while eating, talking, or driving. The cardinal symptoms include 1. Excessive daytime sleepiness, EDS, almost like an irresistible urge to sleep during the day. 2nd, cataplexy, a sudden loss of voluntary muscle tone, often triggered by strong emotions. 3rd, sleep paralysis, temporary inability to move or speak while falling asleep or waking up. 4th, hallucinations, vivid and often frightening experiences at the onset of sleep or upon waking. To diagnose narcolepsy, a detailed clinical evaluation is critical. 2 primary tests are the polysomnogram PSG and the multiple sleep latency test, MSLT. The PSG monitors multiple body functions during sleep, while the MSLT measures how quickly someone falls asleep during the day. Although there's no cure for narcolepsy, medications and lifestyle changes can help manage the symptoms. Stimulants like modafinil are prescribed to combat EDS. For cataplexy, antidepressants or sodium oxybate might be prescribed. Beyond medicines, scheduled napping, short, regular naps can alleviate EDS. Also, maintaining a strict sleep schedule. This ensures enough nighttime sleep along with avoiding alcohol and caffeine before bedtime to promote good sleep. The etiology of narcolepsy has puzzled researchers for years. Recent studies have pointed towards an autoimmune cause. Certain genetic markers, like the HLA-DQB602 allele, have shown to be present in a significant number of narcoleptic patients. Moreover, there's compelling evidence linking narcolepsy onset to a particular strain of the H1N1 influenza, and the subsequent vaccine used in Europe. This supports the theory that narcolepsy might sometimes be triggered by external factors in genetically susceptible individuals. Movies and TV shows often portray narcoleptic individuals as comically falling asleep mid-action. Such depictions perpetuate stigmas. Awareness campaigns are essential to educate the public about the challenges faced by those living with narcolepsy. The clinical community is already buzzing about the potential of immunotherapies for narcolepsy, given its possible autoimmune basis. But like the previously discussed SPRINT study about blood pressure, it's crucial to move with caution, ensuring rigorous testing before accepting new treatments as standard. In conclusion, narcolepsy is a multifaceted condition that demands a comprehensive understanding. Early diagnosis and a tailored treatment approach are vital. Every narcoleptic patient deserves a personalized strategy, and it's our responsibility to ensure they receive the best care.